All right. Good afternoon, everybody. It is noon our time here on the East Coast of the US. So we're getting ready for the last C-Star lecture in our series for 21-22. And I'm really excited about today's speaker. Before I announce Dr. Roy Hamilton as today's speaker, I want to alert you not to the next lecture in 2 weeks' time, because we won't have one. This is the final one of the season, but we will be back at the end of August with a new season of C-Star lectures. If you're on the call now and you can think of people that you would like to hear speak, please feel free to send me a message. You can also try to self-nominate. We typically look for speakers in that are prolific authors in our area, which is the study of aphasia recovery, but that area is very broad. So today it gives me great pleasure to welcome Dr. Roy Hamilton. He is an associate professor in the departments of neurology and physical medicine and rehabilitation at the University of Pennsylvania, where he also directs the Laboratory for Cognition and Neural Stimulation. He completed his medical training at Harvard Medical School and as a clinically trained behavioral neurologist and a cognitive neuroscientist, he has dedicated his career for over 20 years to exploring the structure, function, and the network function relationships that underpin complex human behaviors. He has over 10,000 citations. That's really impressive. A large focus of his research has been studying TMS, so transcranial magnetic stimulation, and transcranial direct current stimulation in a range of studies, exploring topics like cognitive control, visuospatial processing, language production, semantic memory, and creativity. And some of his most recent publications have focused on understanding neuroplasticity in the language system through neuromodulation and the application of neuromodulation procedures to treat disorders of communication. That's also what he'll be talking about today, I think. He also works on racial and gender-based disparities in neurology and healthcare. He is also the recipient of numerous accolades, among which not least the American Academy of Neurology's Norman Geschwind Award for Behavioral Neurology Research. I could, of course, go on, but I think it's time to introduce Dr. Roy Hamilton and his talk, Stimulating Conversations, Employing Non-Invasive Brain Stimulation Technologies to Characterize and Enhance Language Processing in Persons with Aphasia. The floor is yours, Roy.
Well, thank you, Dirk. That was really such a lovely and complimentary introduction. It is really an honor to be able to speak in the last session of this series for the academic year. As I was telling Dirk, my lab often, when we have a gap in no scheduled speaker, or sometimes we actually schedule it in, we get together and we watch C-Star videos. So being able to give this talk feels to me a little bit like being able to be on a television show that you like to watch. So so thank you for this honor. I have no relevant financial conflicts. We're going to spend the next hour or so talking about this topic of non-invasive brain stimulation and different types of non-invasive brain stimulation for different kinds of aphasia. And the way I'm going to describe this talk overall, if I had to give an overall summary, I would say that it is about 1/3 historical, about 1/3 allegorical, and about 1/3 aspirational. And what I mean by that is we've been at this for a few years now at the University of Pennsylvania. So some of this will be a historical walkthrough of some of our work and some of the ideas that motivated our work at the time. A lot of that's going to be framed around a simple story, and I would argue an oversimplified story about how the two hemispheres of the brain interact in individuals with aphasia and how the field of non-invasive neuromodulation has tended to view that. And then the third piece will actually focus on where our lab, and I think to some extent where I think the field is going with respect to non-invasive neuromodulation in individuals living with aphasia. So here's our roadmap for today. First, we'll talk about interhemispheric interactions in individuals with non-fluent aphasia. And the reason why I'm going to focus on that is that it has historically motivated both some degree of controversy, but also a lot of the approach that many individuals, initially including our lab, I would say, have taken with respect to the use of non-invasive neuromodulation, particularly transcranial magnetic stimulation in persons with aphasia. So we'll have to start there as a jumping off point. And then I want to move on to talk about the use of TMS for post-stroke aphasia, the use of transcranial direct current stimulation or electrical stimulation for individuals with post-stroke aphasia, as well as for individuals with neurodegenerative aphasias, so-called primary progressive aphasias. And then finally, as I said, I want to talk about challenges and next steps for neuromodulation in this field. So as I'm sure a number of you know, when individuals with chronic aphasia are engaging in various language tasks, they can engage a number of brain areas or constellation of brain areas that differs from the typical constellation of brain areas that we see engaged or activated when healthy language users are performing similar tasks. So this slide now, again, in the historical portion of our talk, this slide comes from Peter Turkeltaub, who many years ago was a fellow in our lab when he did this work, and then has since moved on and is, of course, an aphasiologist and cognitive neuroscientist in his own right at Georgetown. And what he did here was an AL meta-analysis of all the articles that had been collected up until the point in time which he did the analysis, which is actually several years before what's listed down there, demonstrating that individuals who were healthy controls, as indicated in the top row there, activate a number of predominantly left hemisphere areas that we're all familiar with. But compared to that, individuals who have chronic aphasia as a result of stroke, performing the same exact tasks, may engage a bilateral constellation of brain areas. And in many cases, that bilateral constellation of brain areas, including regions that can be viewed as homotopes, sort of mirror areas or near mirror areas of regions in the left hemisphere that are typically activated in healthy language users. Well, that raises a question that, as I said, for a number of years was a relevant one to the application of non-invasive neuromodulation, or at least to studies pursuing non-invasive neuromodulation in aphasia recovery. And that is what the right hemisphere is doing. What is its role when it's being engaged or activated in individuals who have aphasia? And so I want to break this down. As I said, we're going to break it down to a pretty simple story. And so we can break it down into the simplest possible categories of what could be happening when the right hemisphere is activated in a person with aphasia who's trying to perform language tasks. So, one pretty simple idea is that it's somehow compensatory. It's somehow helpful that individuals engage these areas that hitherto hadn't been engaged during these language tasks. Another hypothesis, however, and one that has at least some traction, we'll go into why people think this, is that the right hemisphere could be harmful, that its effects could be either noise or directly deleterious with respect to the performance of language tasks. And I'll say a little bit about why that might be the case, or why some people think that might be the case. I think perhaps a more complex view is that perhaps it's got some elements of each, right? That perhaps there's a compensatory component, but the picture is more complicated, and that there might be ways in which this engagement of additional brain areas has certain inefficiencies, or certain ways in which it might be dysfunctional, even as it is simultaneously in some ways compensatory. And then finally, just to round out our set of broad options, it certainly could be the case that this pattern of activation is epiphenomenal, right? It's there, but it's not actually relevant to the performance of language tasks. So it means nothing. So let's talk about at least a little bit of evidence for some of these ideas, right? And where that evidence takes us. So first, as far as evidence to support the compensatory role of the right hemisphere, we can actually look as far back as the 19th century. This is actually a page taken from an article from the British Medical Journal in 1877. It's from a case reported by a doctor named Thomas Barlow of a 10-year-old child who had stroke as a result of infective endocarditis. So an infection in the heart that's throwing clots to various parts of the body, including the brain. All right, so unfortunately, there were not very good cures for infective endocarditis. So this 10-year-old boy did have a stroke, and the stroke resulted in a boy having aphasia. So here's how Thomas Barlow describes the boy's aphasia initially. He says, he had lost his speech. He could only say, ha ha. He could not grasp with the right hand, and he dragged the right leg when put on his feet. And so for those of us who are familiar with strokes, it sounds like he had a large stroke, probably the left, or a stroke of the left hemisphere, with resultant right-sided paresis. But like many children who have strokes, he actually had a pretty good recovery, and a very plastic brain. So here's how Thomas Barlow describes his recovery. In 10 days, he was greatly improved. The speech had returned on the 10th day, but occasionally he made a mistake, gave the wrong name for a boy, and did not always seem quite to understand what was said to him. In a month's time, he seems to have quite recovered. So great recovery from the stroke and aphasia for this child. Unfortunately, as I said, what did not exist in 1877 were good treatments for infective endocarditis. So unfortunately, this child had a second stroke. And when he had his second stroke, here's how Barlow describes his symptoms. The only approach he could make to a voluntary articulate sound was ah. He could cry vigorously. There was no lack of voice. From his admission, he appeared to understand all that was said to him. When asked his age, he counted to 10 on the questioner's fingers, counted 4 when asked how many brothers he had, and so forth. He made signs for what he wanted, and the signs were correct. So again, a recurrence of this child's difficulties with language production, a recurrence of his aphasia. Well, unfortunately, in the absence of good treatments for infective endocarditis, this boy died. And when he went to autopsy, as one might expect, Barlow did see that he had a stroke in the left hemisphere of the brain, but also he had a second stroke, a newer stroke, that stroke being in the right hemisphere, in a region of the brain that's analogous to areas that we would expect to be relevant for language in the left hemisphere. The point being that this case presumably suggests that at least some of this 10-year-old boy's recovery from his first stroke, which gave him aphasia, was mediated to some extent by his right hemisphere, as suggested by the fact that a second stroke of that right hemisphere resulted in a recrudescence, a recurrence of his symptoms. Right, and there are other case study examples. You can glean inferences from things like WADA studies, or studies in which individuals have certain parts of their left hemisphere surgically removed for medical reasons that suggest that the right hemisphere may be able to play a compensatory role. So let's look at the opposite hypothesis, why it might be the case, or why it would be the case, that the right hemisphere's activation in persons with stroke and aphasia would actually be deleterious. So this idea, which has been kicking around now for more than a decade and significantly more, actually comes to the idea that the two hemispheres are richly connected to each other via the corpus callosum, which we all know. If you test the connectivity, if you interrogate those connections by, say, stimulating one side and recording from the other, or stimulating from one side and then seeing what the effects of stimulating the other side are immediately thereafter, what you see is that at least in motor physiology, I'll show you in a second, many of those connections between the two hemispheres seem to have an inhibitory impact on one another, right? And so this leads to the idea that perhaps the increased activity of the intact hemisphere after a unilateral lesion isn't reflective of some coherent task-related and task-specific activity, but rather a release of inhibition from the normal inhibitory inputs of the damaged hemisphere. Right? And so by that model, that increased activation would be noise. What could be worse, however, is that increased activation could actually increase the projections, the inhibitory projections that are projecting from the intact hemisphere to the damaged left hemisphere in the case of individuals with left hemisphere injury and aphasia, right? And in that way, potentially suppress recovery. Right? And so this just illustrates that this is demonstrable in motor physiology. So what I'm showing you here is individuals who have had, or a cartoon representing individuals who have had strokes involving the motor cortex. It's possible to demonstrate that if you were to try and stimulate over their motor cortex on the injured side, and you recorded obviously from the contralateral side, you'd have a diminished response, reflective of the fact that their motor system's been injured. But if you measured from the other side, the contralesional side, the intact side, you would actually find that you have an increased response on that side, right? And that the idea there being that that increased response is actually a release from inhibition. And subsequently, there are two potential approaches that you might adopt to try and level out the level of motor output or physiologic output from the brain. You could try to facilitate the activity of the damaged side, or another approach might be that you would try to inhibit that increased activity of the intact side to try and restore that balance. Right? And this what I'm showing you is data from a number of years ago, and I'm picking this because it was sort of reflective of some of the arguments at the time. This comes from an fMRI study in which they put patients with chronic stroke and aphasia in the scanner and had them perform a naming task. And as they're performing picture naming, they basically looked at how the brain was activated during correct responses and incorrect responses. And if you just look at the bottom line, literally, is that when individuals were performing the task incorrectly, that's when they were more likely to engage their right hemisphere. So individuals who believe in this interhemispheric inhibition hypothesis would then argue, that increased activity of the right hemisphere is noisy at best, but potentially deleterious, potentially degrading the ability to perform the task at hand. So as I showed you before, Peter Turkeltaub, when he was in our lab, did an AL meta-analysis demonstrating these different areas of activation in the right hemisphere. Now that in and of itself doesn't have any purchase on this question of what the right hemisphere is doing, but we then did ask just two simple questions that I think have some relevance to this discussion. So the first was whether or not an area, say in the right hemisphere, was a homotope, meaning, well, okay, is it analogous? Is it sort of a mirror image area of an area in the left hemisphere that typically in an intact language user mediates language? Okay, but the second question is whether it's a homolog. In other words, if you look across all the tasks where all these data were compiled, is it the case that area of the brain is active when its next door neighbor in the left hemisphere, in intact language users, would be active, and not active during the tasks when it wouldn't be active in the left hemisphere for across the range of tasks? Because if the answer is yes, well, when the left hemisphere area is active, this right hemisphere area is also active. If they track very closely, well, that suggests the right hemisphere is doing something at least coherent. If the patterns of activity are fairly orthogonal, if they're fairly unrelated to each other, that suggests that maybe it's not as related, potentially noisy, potentially even deleterious. And to make a long story short, practically every region that we looked at in the right hemisphere, well, first of all, most of them were homotopic and homologous as well in terms of their patterns of activity, with one notable exception, the pars triangularis on the right. Think of it as being analogous in location to Broca's area, but in the right hemisphere, so in the inferior frontal gyrus. And so that affords us a specific location where we could ask ourselves whether modulation of the activity of that region might have some kind of beneficial result with respect to language performance. And so this is where I want to introduce the first workhorse of our laboratory. That's transcranial magnetic stimulation. Now, by now, I'm sure many, if not most of you, are at least somewhat familiar with transcranial magnetic stimulation. So I'm sparing you a long, drawn-out description of the technology. Suffice it to say, it involves placing a coil on the scalp, running an enormous amount of current through that coil over a very short period of time, creating a fluxing magnetic field. That fluxing magnetic field takes advantage of the principle of electromagnetic induction. It induces current in underlying cortical neurons that is sufficient to cause them to depolarize. Right? It has a number of advantages as a cognitive neuroscience tool. It's relatively high resolution. I mean, think about a centimeter and a half squared on the cortical surface. So maybe something about the size of your thumbnail on the surface of the cortex, which is pretty good considering you're hitting it from the outside with a magnet. It can be delivered in sequences that either excite or inhibit the cortex. This will be relevant in a minute. Depending on the pulses and patterns, the way that the pulses are patterned, you can achieve one of those two effects. It is very safe. There's a very low risk of seizure, which is essentially non-existent or almost non-existent when we adhere to existing safety protocols and parameters, which we do. And if you apply TMS repeatedly, you can induce lasting changes in cortical excitation and patterns of cortical activity. We think via multiple mechanisms of plasticity, including but not necessarily limited to things like long-term potentiation. So in our earliest endeavors, what we did was we brought individuals in, patients with chronic non-fluent aphasia, and we had them undergo an MRI so we could target our stimulation, and we use MRI to guide to the coil to specific anatomy, and did baseline language testing. And then we engaged in a phase that I like to refer to as site finding. We more or less hunted around the right hemisphere, applying inhibitory stimulation in hopes that we would find a site that for each individual would cause a temporary improvement in their ability to perform a language task. That the particular language task was picture naming. And if we found a particular spot that was able to induce a significant change, at least transiently, in picture naming, well, then we chose that spot for that individual, and they either received sham TMS or real TMS, and followed up 2 months later. Now, we didn't have the heart to make all the folks who received fake TMS or fall out for 6 months. So after 2 months, everyone who would receive sham TMS crossed over into the real TMS arm, and everyone received TMS followed up 2 and 6 months later. And so, basically what we're able to demonstrate is that individuals had an improvement in a variety of different areas of language production. What I'm showing you here is increased performance in naming that actually accelerates. It sort of gains significance at the 6-month point compared to the 2-month point. I should mention that there is one flaw, one highly evident flaw of this graph, which because of the reasons why the graph was generated, it doesn't actually show the sham data. So I want to say that the sham data is a flat line, and you don't see any benefit in individuals receiving sham. We also did fMRI, and what we found actually was a high degree of variability between our subjects in terms of the patterns of activation, both in the damaged left hemisphere as well as in the right hemisphere. And one thing I'll point to, which I will make a more specific point about this later, is that when we applied TMS, inhibitory stimulation, what we did not see was just a monolithic, a sort of universal decrease, diminution of activity during language tasks of the right hemisphere. We often saw some shifts. Those shifts were variable in their nature, but it wasn't that we just silenced that activity in the long run for these individuals. More on that in a moment. Well, we have found that these individuals were able to not just name to pictures better, but also were able to generate better elicited spontaneous speech. So I'm sure many, perhaps most of you, are familiar with the cookie theft picture. And so we asked individuals to describe as much as they could describe in this scene. And we found that individuals who received TMS were better able to generate nouns and verbs and closed class words and open class words and just more narrative words in general. It's really important to point out here that it wasn't that individuals were speaking for any longer, and it wasn't that individuals were speaking any faster, right? These would be very mundane reasons why a person generated more words. It's that during the time that they were speaking, they were making fewer false starts, fewer errors, right? And more time on, and had more time on target. So this part of the talk being historical, a number of years have passed, so we're not the only ones to have done this. A number of studies now have demonstrated that applying inhibitory stimulation to the pars triangularis on the right seems to have a beneficial effect on a number of language measures. So this comes from a meta-analysis that we did a number of years ago, demonstrating that across studies, there's an effect that favors the use of RTMS over sham. Now, remember I said that in our early work, we hunted around the right hemisphere. We looked for a spot that for each individual was the ideal spot. Now, it turns out that we found a spot for everyone in the trial. And it turns out that for most people, the best spot was the same spot. So if you look across this sort of color-coded, these color-coded spots, you'll see that most commonly, individuals had a positive response to stimulation, at least temporarily, in the inferior frontal gyrus of Brodmann's area 45. What people sometimes refer to as the pars triangularis. And if that sounds familiar, that's because it's that same region that in that AL meta-analysis that we talked about and subsequent analyses that we talked about was identified as the one area that was not homologous with respect to its patterns of activation compared to left hemisphere language areas and healthy language users, right? And so one hypothesis that we generated at the time was that, well, maybe much of the right hemisphere is compensatory in nature, and we're making a specific modulation of what one might think of as a kind of noisy node, right? That it isn't the case that the whole right hemisphere is deleterious in its contribution, but that we're making a more specific modification. Now, it isn't necessarily the case that what I just told you, the evidence I just gave, actually indicates that the right hemisphere's role is generally compensatory or that it's beneficial. And you wouldn't necessarily be able to infer that by the fact that you inhibit one spot and language performance seems to improve. However, we did have a particular case like Barlow that suggested to us that indeed the right hemisphere's role is not monolithic. It's not that the entire right hemisphere is deleterious in its contribution and we just pick the worst spot, but that the story is more complex. So this is a set of fMRI images from one of our subjects, and this is actually before and after, and the subtraction of before and after, immediately receiving TMS, inhibitory TMS. This person, like many of our other subjects, responded best to stimulation of the pars triangularis on the right. And so you can see there in the bottom set of images that indeed there was inhibition, or at least a decrease in bold signal after inhibitory stimulation of that region. And unfortunately for this subject, who, like I said, was initially a responder to right inferior frontal gyrus stimulation, she suffered from a second stroke. Again, much like Barlow's patient. It turns out that she had an underlying malignancy. And for those of you who aren't familiar with this medical fact, cancers can make you hypercoagulable, and she's having strokes on the basis of that. And so in case you can't see it well, in the set of images labeled B, these are diffusion weighted images. Those bright spots on the right side are a subcortical infarct, or a set of areas affected by subcortical infarct. Now, if you were a hardline interhemispheric inhibition adherent, you might argue, okay, well, it's never great to have strokes. That's true, and maybe other domains of her language might be impacted, but if the right hemisphere is sending excess inhibitory input to left hemisphere areas that are trying to recover in this person with aphasia, well, maybe it's actually for the language domain at least, a useful thing to have a lesion of the right hemisphere and right hemisphere white matter that might undercut some of this inhibitory input. And well, it turns out that is not the case, and that in fact, just the opposite as what that person would have predicted happened. In fact, this patient had a selective decrement in her language ability, both in naming, which I'm showing there on the left, and then sort of a broader measure of various language abilities is demonstrated there in the Clickett composite score on the right. And so in our minds, we thought that this put the nails in the coffin of the idea that the right hemisphere as a whole is somehow monolithic in being deleterious in its contribution to language recovery, and that we're doing something much more specific when we're applying magnetic brain stimulation. Now, before I say anything else, I have to give a caveat, which is that recent imaging evidence suggests that the interactions that I've been discussing may be different for different kinds or different locations of lesions. So this is from a couple of years ago now, but it's a study that demonstrates that looking at patterns of brain activity serially in individuals who are going from the acute to the subacute to the chronic stage of stroke, that individuals with more frontal lesions seem to have a different pattern of engagement and activation than individuals with more posterior lesions. Specifically, the individuals with more frontal lesions tend to have more robust activation of regions on the contralateral hemisphere that one would think of as homologous, as opposed to the more posterior lesions, at least according to this study. And since we've historically focused on individuals with non-fluent aphasias, we've been heavily biased towards individuals with more anterior lesions. So it might be specific to the patient population that we've been dealing with. So let me just summarize the work that we've done, and this sort of historical component of our work. Somewhat tongue-in-cheek, I'm going to describe this as 5 years of our work summarized in 4 words. So let's return to those 4 options I talked about before. Is the right hemisphere, is it just compensatory? Well, probably not, because if it were, so first let's eliminate the most obvious thing we can eliminate. I wouldn't have just spent the last 15 minutes talking if the answer were that the right hemisphere is epiphenomenal. So yeah, let's take nothing off the table. So now let's talk about whether or not the right hemisphere is just helping, just compensatory. Well, probably not, because if so, then applying inhibitory stimulation probably wouldn't have a beneficial effect. But by the same token, it probably isn't the case, or it's clearly not the case that it's monolithically deleterious, right? Because if that were the case, then you might not anticipate that additional lesions of the right hemisphere would have such a dramatic effect in individuals with aphasia, both in the 19th century and today. So, to paint with broad brushstrokes, our bottom line, we think that we're doing something much more specific when we're applying transcranial magnetic stimulation to the right hemisphere in inhibitory ways to try and elicit benefits in language performance in persons with aphasia. So shifting gears slightly, I want to talk about the other workhorse in our laboratory, transcranial direct current stimulation. And while people often mention these 2 methodologies in the same breath, they're actually quite different with respect to their mechanism of action. Most importantly, tDCS applies sub-threshold stimulation on the order of milliamps. So this is the kind of thing that just nudges millions of neurons either a little bit closer or a little bit farther away from their actual potential firing threshold. It doesn't cause the same kind of instantaneous depolarization that TMS can. And so the net effect of this very subtle influence is to alter firing rates of assemblies of neurons. It can be given, at least one of those electrodes has to be an anode, at least one of those electrodes has to be a cathode, right? The current has to travel between the 2 polarities. And so you can apply stimulation of either polarity. And the received wisdom is that anodal stimulation is more often associated with excitatory effects and cathodal stimulation with inhibitory effects, although you can certainly find exceptions to that in the literature. It is, if TMS is safe, this is very safe. In the history of the device, there have been no reported serious adverse events. And like TMS, with repeated usage, you can see changes in behavior, changes in cortical activity that we think are, again, related to multiple mechanisms of plasticity, including but not limited to long-term potentiation. So one important difference, just methodologically, between TMS and tDCS is spatial resolution, right? Conventional tDCS, using relatively sizable electrodes, has pretty poor spatial resolution. The current just wants to get from one electrode to the other, and makes its way very diffusely through the brain and other tissues on its way there. So what I'm showing you is a finite element model of the flow of current between the two electrodes in a very commonly used electrode montage. Now, if you're a cognitive neuroscientist and you have a very specific question that you're trying to ask and answer about a particular site in the language system or in the brain that you think is mediating some specific cognitive operation, that's sort of a disadvantage. But if you are trying to stimulate a bilateral, network of brain areas, most of which you think are useful for some cognitive operation. For example, a bihemispheric network of areas that are engaged in language performance and language recovery in persons with aphasia, well, perhaps diffuse stimulation is in fact what you want. And so in some of our early work, we brought in individuals with chronic aphasia, subjected them to a very similar kind of protocol to what we did in individuals with post-stroke aphasia in a first kind of montage site finding visit. They would get tDCS, and, the anode to the left hemisphere, the cathode to the right hemisphere, or the anode to the right hemisphere and the cathode to the left hemisphere. Basically look for a montage somewhat agnostically that would be of greatest temporary benefit to these individuals, and then applied either sham or real tDCS for 10 daily sessions across 2 weeks, and had, again, a partial crossover in which individuals who received sham eventually received real stimulation, and were able to demonstrate that we have persistent beneficial effects in individuals with chronic aphasia who received tDCS. Now, here I had the common sense to actually include the sham arm in the graph. You can see that individuals who receive real stimulation have much greater effects than individuals who receive sham. And on the y-axis, I'll point out that we're not just talking about specific language tasks like naming and other very selective tasks. This is the change in the Western aphasia battery aphasia quotient for these individuals. And so, a not insignificant change in these individuals with respect to their overall aphasia severity. And as I've said, time has gone by and multiple people have been in this arena over the years. I'm not going to even try to claim that we're the only ones. And this comes from a meta-analysis that we did a number of years ago of all the literature up until that time, demonstrating that indeed across a variety of studies, there is an effect that favors tDCS compared to sham. I would be remiss if I didn't point out one specific study that isn't ours from a couple of years ago, simply because it's one of the biggest studies to date, perhaps the biggest study to date to use tDCS in patients with post-stroke aphasia and demonstrated effect. And that's from Julius Friedrichsen's group in 2018. So, using a group of, or studying a group of 74 individuals, they were able to demonstrate that individuals who received anodal stimulation had, first of all, that their first analysis was a non-futility analysis. So their first demonstration was that doing this was not futile. They couldn't reject they could, I guess, reject the hypothesis that it was futile. And then their subsequent analysis demonstrated that, in fact, there was a significant benefit for individuals who received anodal stimulation compared to sham stimulation. In recent years, we have been applying the same technology to individuals who have neurodegenerative aphasias, primary progressive aphasias. Chances are I don't need to explain to this group the different primary progressive aphasias, so I, by and large, won't, except to say that there are 3 identified subtypes of PPAs, each of them associated with a different pattern of cortical atrophy, as demonstrated here in this image. There's a non-fluent, typically agrammatic variant of PPA, so-called semantic variant of PPA, which is often associated with that atrophy of the temporal lobe, and logopenic variant PPA, which the underlying pathology is often demonstrated to be the underlying pathology of Alzheimer's disease. And so we started out taking a very broad approach. So what I want to show you on the right there is this is a different kind of or a different way of viewing current modeling. So I'm showing you the three views and where the current flow was with the electrode montage that we initially selected. And we selected a montage that we thought would basically hit most of the Perisylvian language system, right? Because we wanted one montage for all three of these aphasia subtypes, right? And so as you can see, we're trying to hit more or less all of the left hemisphere as it's involved in language processes. And so, in our early results, we actually had initially an open label study and had very promising results with respect to measures of speech production, repetition, grammatical comprehension, semantic processing. We made a composite measure that was a global measure that in which there was a significant benefit. More recently, we've employed a sham control arm, and now we're, as I'll talk about in a few minutes, engaged in a couple of clinical trials ongoing, for which I'm not going to sort of let the cat out of the bag about about those results because they're ongoing, but at least in our early results, demonstrate that we could also demonstrate a significant benefit in individuals receiving tDCS in a variety of different language tasks compared to individuals receiving sham. And one interesting thing that we discovered in some of our early results is that our individuals who started with lower baseline performance seemed to demonstrate a greater benefit than individuals who started off with better performance with respect to their baseline language abilities. Now, if you're a statistician, or even if you're not, you might argue that might simply represent regression to the mean, and there might be some component of that, if to be honest. However, if you think about many language therapies, you would argue and observe that often the severely affected individuals are not actually able to engage that meaningfully in the therapy, and aren't the ones who benefit the most from those therapies because of their inability to engage in them often. And so the fact that we have an intervention where it seems like some of our individuals who are most affected seem to be some of the ones deriving the most benefit, at least to us, has been heartening. Again, I would be remiss if I did not mention a different pioneer in this field who's been doing great work and has some of the largest published data sets out there, and that's Kiran Satkini at Johns Hopkins. And so, this comes from her paper in 2018, with this time with 36 individuals with PPA. Again, demonstrating some of the same results and extending some of the results I was talking about, or benefits in various aspects of production for individuals with logopenic variant PPA and non-fluent agrammatic PPA. I think both her group and our group have tended to find that individuals with semantic variant PPA have been less responsive. All right, so in the last few minutes, I want to talk about where we are and what's next. In other words, I want to summarize what I think our labs learned over the course of the time that we've been doing language studies with neuromodulation, and where I think we need to go, and then give a couple of examples. So in terms of the insights we've achieved, first, I hope that I've shown you that there are numerous encouraging proof of concept studies in neuromodulation for aphasia, but also there's currently insufficient clinical data to justify the widespread use of these technologies in persons with aphasia. So this is self-evident what the next step is here. That's to conduct larger randomized controlled trials. I also hope I've shown you that interhemispheric inhibition has, well, it's been a useful initial framework. I think it's been said all models are wrong, but some are useful, right? So it's a model that has had its uses. However, the models that guide neuromodulation are oversimplifications at best, right? This one specifically, in my opinion. And so we need novel tools and models to characterize language system plasticity. Specific approaches, for example, 1 Hertz repetitive TMS to pars triangularis, well, they seem effective, right? We have promising data, but we don't know if other sites and parameters are useful. So we need novel mechanistically informed sites and stimulation parameters. And individual responses to neuromodulation vary widely. And part of the problem here is that we lack evidence regarding the factors that predict response to neuromodulation. So we need to explore predictive patient features and look for intermediate markers of plasticity. So let me say a word about some of these points that I've made. So as far as more and larger trials, so we're currently engaged in a phase 2 clinical trial in our lab applying transcranial magnetic stimulation in individuals with chronic aphasia using that inhibitory approach in the pars triangularis. Branch Coslet is actually the PI of that particular proposal. And so it's several years in now, and hopefully we'll have one of the larger cohorts of individuals who have had this kind of stimulation applied to report to you in a couple of years. Simultaneously, we're conducting 2 clinical trials, one supported by the Department of Defense and the Department of the Army, and the other supported by the NIH, using tDCS, and also, in addition to the sort of conventional sponge tDCS, so-called high-definition tDCS uses smaller electrodes to deliver more focal tDCS in individuals with primary progressive aphasia. And hopefully, there will be a multi-site clinical trial starting in July of this year, at least the funding starting in July of this year, in collaboration with Kiran Sapkini at Hopkins and also Howard Cherkow and his group in Canada. We're very interested in the factors that predict response to neuromodulation, and also relatedly, whether neuromodulation itself can be used as a factor that predicts response in aphasia. So let me say a word about how we study that. For those of you who aren't too familiar with TMS, you can, most of you know that you can apply a pulse of TMS and study its motor output, right? The physical result of stimulating over the motor cortex immediately, something called a motor evoked potential. Okay, you can then apply other patterns of TMS after you acquire a motor evoked potential that say excite or inhibit the motor cortex, and then you can acquire more motor evoked potentials sequentially to figure out what the effect was of your modulatory stimulation and how long that modulatory stimulation lasts, right? And so by giving a run of TMS that temporarily alters brain activity and then measuring the subsequent its effect on motor output, you can get a sense of how responsive that brain is to stimulation. And you can think of that more broadly as, well, how responsive is that brain to perturbation? How plastic is that brain? All right, so for those who don't think about this a lot, I like to use the metaphor of memory foam, right? So when you press down on the memory foam, you take your hand away, there's an impression there for a while. The length of time that it holds that impression it gives you some kind of index of the plasticity of the foam that you just pressed into, right? And so this is sort of analogous to what I'm talking about. So what we've demonstrated is that genetic features that are really that are known to be important more broadly for neuroplasticity are important with respect to responsiveness to TMS. In particular, the one we've been looking at is brain-derived neurotrophic factor, or BDNF. Right? And what we can demonstrate is that that depending on your genotype of BDNF, you have a very different response to this test of motor system plasticity or brain plasticity. About 3/4 of the population has a more common genetic variant, the Val66 variant. About 1/4 of the population has the less common and generally less plastic variant, the Val66 MET variant. And what we can demonstrate is that in individuals who have the more common variant, you see the typical response to stimulation. And individuals who have the less common, less plastic variant, you see very little response, or at least a severely delayed response to this TMS assay of plasticity. And we see this in individuals. We measure this in the cohort of individuals with stroke and aphasia as well, and the result holds. And what we can also demonstrate is that BDNF genotype actually plays a role if you use it as a factor in a predictive model in individuals with chronic aphasia, and you factor in all the other things you would expect to influence their recovery, their lesion size, location, all the other things that are intuitive, that genotype has a significant effect with respect to predicting aphasia recovery in these individuals. Moreover, if you then take the individuals who have the less plastic genotype and you see whether or not that TMS measure of plasticity has any purchase, you can then also demonstrate that measure of plasticity in those individuals with the less common genotype, it also adds predictive value with respect to their ability to recover from stroke and aphasia. So, these factors, sort of genetic features, aphasia recovery, and TMS as a physiologic marker of plasticity are all interacting in these populations in ways that we hope in the future will be able to give more information about how individuals will recover from aphasia in general and respond to brain stimulation more specifically. Lastly, I want to focus on some of the work that we've been doing looking at anatomical language network properties and their ability to predict response to TMS. So, this is largely work being done with John Medaglia, who's at Drexel University, right next door to Penn. And so it starts from the premise that cognitive localization in the brain is a function of local and global connectivity. And with that being the case, if you look at a network, let's take this oversimplified cartoon of a network, that you would expect that that node there that's connected to many nodes on a kind of module, that it has a very different role than, say, this node, which kind of integrates and segregates large modules, as opposed to that node, which has a very specific role. It only activates one other node in the system, right? And so we've been using a lot of network control theory, which allows for inferences about the operational utility of brain centers based on their anatomic connections, all right? So we're looking at anatomic connectivity here. Just to be clear, not resting state functional connectivity. We're looking at actual anatomic connections and building networks and characterizing the degree to which different sites in that network exhibit particular network properties or network control properties. So for instance, I talked about this property of being able to integrate and segregate networks. That's called boundary controllability. And this node has a lot of it. I also talked a little bit about the ability to make very, very specific changes to the network, only affect it in a very selective way. That's something called modal controllability. And this area has a lot of it in this particular example. And so we're able to generate individual maps of the degree to which these variables are represented in the brain at different areas in individuals. And so we've started with individuals who are healthy language users, but we're starting to move into populations with aphasia to see whether or not these variables are predictive of individuals' response to neuromodulation with respect to specific language tasks. So for instance, in some of our earliest work, we looked at whether or not Broca's area in individuals who are healthy language users, right, whether factors like boundary control and modal control affected their ability to perform what we classed as open-ended tasks. In other words, language tasks for which there are many solutions, like a sentence completion task, or closed-ended tasks where there are very few or maybe one solution, like a number reading task, right? And so we hypothesized that boundary controllability would be important for the performance of open tasks because it involves integrating and segregating these sorts of large modules. And closed-ended tasks would be more related to a function that involves very specific manipulations of a network. And demonstrated that indeed, if we applied TMS to the inferior frontal gyrus on the left in healthy individuals, that to make a long story short, in the interest of time, let me cut to the chase, that boundary control, that individuals who either had high or low boundary control, right, that boundary control in Broca's area, that impacted how brain stimulation and Broca's area in healthy individuals affected their performance on these open tasks. Whereas individuals who were performing, who had high or low modal control in Broca's area, right, that affected how they were likely to perform on closed tasks. And we've explored this In other ways too, we've been looking at the impact of these network controllability measures on things like word selection and retrieval demands. The bottom line is that we're starting to characterize anatomical network properties of the brain that have some purchase on predicting what will happen when you administer TMS to that part of the brain. Our ultimate goal is to be able to look at these properties in individuals with stroke and aphasia or other causes of aphasia, see if those properties shift as the patterns of brain activation in individuals with aphasia shift, and whether that has any predictive value for what TMS in other brain areas that have, they're engaged in language performance, what the result of TMS in those areas will be. So to conclude, I hope I've convinced you that aphasia engages a bihemispheric post-stroke language network, that focal manipulation of the right inferior frontal gyrus with TMS enhances language performance, that diffuse direct current stimulation may facilitate recovery in both post-stroke aphasia and PPA, and that bigger studies, novel analytical approaches, and better predictors of treatment response are on the horizon for neuromodulation in aphasia. And with that, I thank you. I look forward to any questions and comments.
Thank you, Roy. That's wonderful. Thanks a lot for your talk. That was very educational and interesting to all of our audience, certainly to myself as well. So your first question, it comes from Kirana Tsapkini, who you referred to already in your talk. She says, beautiful talk, thank you. Why do you think you got such a huge variability in TMS response when you so painstakingly targeted their most appropriate brain areas for the task? This is one of the earlier...
The TMS response. Yeah, so I think that there are a variety of factors that probably have to be controlled for TMS in addition to just where you stimulate, right? It may be the case, for instance, that stimulating different individuals with the same intensity relative to the motor cortex might not actually have the same effect. There's a growing body of work now about the use of modeling to demonstrate that, in fact, that stimulation over the motor cortex is not necessarily an ideal predictor of how you need to stimulate each individual at their site, right? Also, I think that there's so we might be stimulating the right persons, but we might not be stimulating them the right way, or at least at the right intensities. Also, there's going to be variability with respect to the lesions in terms of their site, their location, and various things. So even though it might be the best site for an individual, at the end of the day, the potential that they, what kinds of gains they can potentially have as a result of multiple sessions of stimulation might be governed in different ways that aren't necessarily predicted by their response to an immediate session of, one session of stimulation.
Thank you very much. We have a question from Yuan Tao. Thanks for the great talk. Would you expect the same stimulation methods used for post-stroke aphasia also apply to PPA, for instance, inhibiting the right hemisphere homologs?
That's a great question that we'd like to know more about. Before I say anything else, someone has, from my own lab, has reminded me to put in the chat that we're hiring at a couple of different levels. So I'm going to throw that out while I still have time, RAs and postdocs. Right. So there, I did it. So now the question is, can we say the same thing about the right hemisphere for individuals with PPA? And the answer is, I don't know. The field has been generally far less focused on contralesional, or I guess, right, it's not even fair to call it contralesional in neurodegenerative diseases, because probably there's degeneration happening to some extent broadly, right? But on the less impacted hemisphere in individuals with PPA, there's some evidence that suggests that it might be engaged in individuals with who have primary progressive aphasia, which suggests that yes, maybe a future strategy would also be to try and stimulate the right hemisphere. Now, how we would stimulate it, to what extent are different sites compensatory, inhibitory? Is it mixed? I mean, those are all questions that would need to be sussed out in the future.
Great, thanks a lot. We have a question from Sigfus Christensen, who is right here in South Carolina in the Aphasia lab with Julius Fredrickson as well. Thanks for a highly intriguing talk. Thinking ahead, do you foresee non-invasive brain stimulation becoming a widely used approach to augment conventional aphasia therapy? If so, how can treatment efficacy be maximized with the addition of non-invasive brain stimulation approaches?
Well, I think that's the goal, right? That's the dream, is that we pair neuromodulation with aphasia, behavioral aphasia interventions. I think it's especially relevant to the application of tDCS. I mean, I think it's relevant to both technologies, but let me just say why I think it must be the case with tDCS. So tDCS is a sub-threshold stimulation technology, right? It doesn't activate patterns of neurons in coherent ways. What it does is it makes it a little bit easier for some pattern of neurons to be activated. And so intuitively, you should be pairing tDCS with some type of behavior that you think is relevant to the thing that you want to be reinforced, right? And so it's a very natural fit that you would pair it with behavioral language interventions. So the key questions are, which behavioral language interventions would be most relevant? Which circuits do you want to activate, right? And so all the questions that get asked and answered by individuals who are interested in behavioral language interventions when they're thinking about their effects on the brain, they're directly germane to our application of non-invasive neuromodulation to those individuals, because what we're basically trying to do is enhance the and reinforce the gains that are being induced by the behavioral intervention.
Thank you. I was typing another question while I'm so that I don't forget. I had a rather a technical question first. So in your experience, do anodal and cathodal traditional stimulation, well, particularly traditional, but actually HDTS as well, have the same directional behavioral effects in speakers with versus without stroke and aphasia?
So this is an excellent question, and I think you get, you get 10 stimulators in a room, you're going to get 11 answers on this. But but what I would say is we've done a little bit of looking into this. Right? It does seem clear, first of all, that it is an oversimplification to think of anodal and cathodal stimulation as having just equal and opposite effects on either physiology and or behavior. Right? I mean, just to give you one example of that, one very well-known sort of fly in the ointment study that was done with tDCS demonstrated, at least in motor physiology, which many of these studies are, that you get with cathodal stimulation over the motor cortex, if you give it at one intensity, you get the inhibitory effects that everyone would predict. You give it at another intensity, so twice the intensity, and then you get a facilitative effect on brain activity, right? So clearly these, the relationship between stimulation polarity and effect on the cortex doesn't have these simple monotonic relationships, right? And so I think I alluded to that by saying that it was the received wisdom, that you can find, I think, on average, more studies in which cathodal stimulation has what would be anticipated to be an inhibitory effect. But you can certainly find lots of results that violate that rule. And having said that, there are a number of labs I know that intentionally apply cathodal stimulation to the right hemisphere and anodal stimulation to the left hemisphere, and swear by that because they're doing, they're using an approach that aligns very closely to the interhemispheric inhibition hypothesis. And I'm not going to say that it's necessarily wrong for them. I would say that you might anticipate very similar responses and similar benefits if it were in fact the case that cathodal stimulation and anodal stimulation didn't have such different effects, and you're stimulating a bilateral network of brain areas. to be engaged in language recovery, right? So a lot has to be done to figure out the relationship between parameter and cortical effect in particular sort of networks, right? In particular brain networks and paired with specific behaviors.
Thanks a lot. There's a lot of basic science that still needs to be done, huh?
Absolutely.
Yeah. Maybe as a last question, unless someone else chimes in, I was wondering if you can say a little bit more about other behavioral factors that are associated with the Val66 MET carrier specifically, that you know of. Like, for example, I can, if because you talked about it as the neuroplasticity or the plasticity variant, right? So do we see anything in like learning, general attention?
Yes, so there is actually some evidence that suggests that there are differences in learning and memory in depending on genotype. Now, obviously, a quarter of the population roughly is walking around with the Val-MET genotype variant. So, that effect is something that you can demonstrate with large numbers of individuals performing these behavioral tasks. Isn't the kind of thing where you can sort out the Val-METs from the Val-Vals just on the street. But yes, it has been implicated in a variety of cognitive operations, such as learning and memory, as well as in other investigations of motor physiology that suggest that the brain doesn't respond as robustly in these individuals when they're receiving stimulation.
I think in that case, that automatically also makes it harder to ascribe the differences that you find in response to brain stimulation directly to the genomic variant, right? It could be the direct effect of having a better attention span and having a better, which is then indirectly an effect of the gene itself.
Oh,
the behavior that is different in
sure. I mean, I would say that we would, one thing that we wouldn't expect if that indirect effect was everything that was going on is that we wouldn't expect that necessarily a cortical physiologic measure of responsiveness would say have any predictive value for the behavioral outcome, because the genetic variance is binary, right? And so we're actually just looking within that group of individuals who have the less common genotype and saying, okay, well, even within this group now, we can use the motor measure as a kind of index of plasticity within this group that seems to have some predictive value.
Great, thank you very much. I think we can end it there, Roy.
All
Thanks
right.
so much for doing your talk. We really enjoyed it.
Thank you for the wish fulfillment of inviting me to speak. So thank you again. It was a wonderful time. Thanks.
Okay, there's a link to the RA position in your lab in the chat box for anybody who's interested. And since Dr. Hamilton is recruiting, I'll also just mention once again, I think I mentioned it 2 weeks ago, that the Aphasia lab in University of South Carolina is recruiting a new PhD student with us to start in the fall. So we're looking forward to hearing from everybody. Have a great summer and see you end of August. Bye-bye.
Take care, everyone.